Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out ce.vcu.health.org/Cribsiders for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Well, Paul and Stuart, we're back. We've done it. This is the Cribsiders.
Wait, hold on now.
Guys,
practice this.
Yeah. I'm sorry. It's hard to break the habit. Of course, this is not the Cribsiders, and you are not Paul and Stuart. What was I thinking?
We have a whole new team. It's like they've been replaced, and it's an alternate universe of MedPeds replacements.
Yeah, I'm really excited. Today is the day. Well, not today is the day, but when people are hearing this, today is the day we are announcing to the world that there is now a pediatric version of what we do on the Cribsiders called the Cribsiders, which we pretty much had to make just because of the name, I think.
Exactly. I think that was the major impetus. Was someone had the idea. I think Chris had the idea of the Cribsiders, and we ran with it. And you're absolutely right. So this is our first.
I'm pretty sure I didn't come up with the name.
I think we give you credit. I think there's a famous quote that the most important thing, the world would be a better place if everyone knew who got credit for something.
Gotcha.
This it might be a misquote. This is our first ever episode of the Cribsiders mashed up with the Cribsiders for a whole new MedPeds spin. We want you to know about the Cribsiders. We're going to start making content. You can check us out on any of your favorite podcast players. But we are joined tonight by our outstanding guest, Dr. Whitney Warren, to discuss cystic fibrosis, a great MedPeds topic. But first, Chris, remind us about the show.
We are the pediatric medicine podcast where we interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and some weight-based dosings of fun about core topics in pediatric medicine. And here's our producer, Clara, with the introduction for our guest.
We have a fantastic MedPeds conversation with our guest. Dr. Whitney Warren is a pulmonary critical care doctor who works in an academic hospital in Texas, where she is the medical director of the Adult Cystic Fibrosis Clinic. Her academic interests include advanced lung diseases, interventional pulmonary procedures, and ECMO. She loves teaching and developing the next generation of physicians. In her spare time, she wrangles her 16-month-old tiny human. Dr. Warren teaches us about the diagnosis of CF in children and adults, the management of pulmonary and extrapulmonary complications of cystic fibrosis, and other new therapies available.
So without further ado, let's get to it.
We're here with Dr. Whitney Warren. We're so excited for you to be on the show. Thank you so much for coming. And we'd like to do some rapid fire questions just to get you know you a little better. Can you give us a one-liner to describe yourself and let listeners know who you are?
Absolutely. I'm a 35-year-old runner, mommy to the cutest tiny human ever, a pulmonologist, an intensivist, and a MedPeds wannabe.
So you did not do a MedPeds like Chris and Justin did? I didn't either. So we're, no judgment.
I certainly wanted to, but career and life circumstances prevented it. So now I'm a part of a subspecialty that is very MedPeds heavy. So I get to dabble in a little bit of both. Yeah,
that's great. That you found a backdoor way into it. That's way
right.
better. Justin and Chris,
shaved off a year.
Yeah, well, I added 3. But
yeah, I was never good at math.
Okay, so I always like to get. I have a huge list of books that I try to get to. Sometimes I read like 50 pages. And I'm like, this sucks, and I throw it out. But give me your best shot. What should I be reading?
Okay. So I've spent a lot of time thinking about this. And I think I stand by people should read what they need to read to get them through whatever it is that's hard about being a physician for them. And right now, when I'm not a physician, I'm a mommy. And so Baby Shark is number 1 on my reading list, followed by Never Touch a Dinosaur. So...
And you know all the hand things for the Baby Shark.
I do. I can do all the hand motions for Baby Shark.
It's a classic story. Disappointing ending, but
they're hungry sharks at the end.
I think that's a very inappropriate pediatric recommendation.
I agree.
Yeah,
it's perfect. So my question is, what is the best advice you ever received as a learner?
I had a couple of physicians tell me who are attending, listen to your patients and don't give up on people. One attending in specific was like, you should do tobacco cessation every time. And I was like, oh, it never works. People never quit smoking. And he was like, don't give up on your patient. Do it every time. Someday they'll quit and then you'll feel awesome. And I think that applies to a lot of things, not just smoking, but just believing in the people that you take care of.
Yeah, I think some of the statistics too, especially on tobacco cessation, there's like a surprisingly small fraction of patients are asked about it. Like they do a survey like, were you asked about this in the past year or told you should stop? And it's like 50% or more say no.
Right, yeah.
Don't fact check me on that, anybody. I just read that. I just read that. I can't remember where.
Well,
Well, and there's some old data that the more you bring it up, the more likely it is people are to quit. So, yeah.
Matt, at my version of Cashlack up here in the Midwest, we actually have metrics that look at and we get data how many times we ask it because we have to do a check mark in our own EMR. Thank you. Oh, I'm not going to say that. I don't know. Bleep that out.
We might have to bleep that.
We'll get a bleep from Lenny Feldman's old episode.
That's Lenny, our previous guest that we bleeped did not like it because all his colleagues thought he was swearing a lot, but he was really just saying the name of an electronic health record and where I worked, both of which are not allowed on the show.
Should we go on to these cases now?
Let's jump into it. Yeah, Chris, you want to start us off with the first case?
Oh, okay, good. All right. Emma is a 3-week-old infant you are seeing because her newborn screen came back with an elevated immunoreactive trypsinogen, an IRT, and further molecular testing showed the CFTR mutation. You meet with her anxious parents to inform them that Emma's sweat chloride level is 67 milliequivalents per liter. And this confirms the diagnosis of cystic fibrosis. I read that really strangely.
You did a great job.
No, I'm good. I think we should just leave it. Let it go.
I put you on the spot.
We'll let it go. So I guess the first question is so these parents are wondering, like, I'm sure they've heard what cystic fibrosis is. What is your sort of like Wikipedia layman version explanation of what cystic fibrosis is?
Sure. So the first thing I do, in full disclosure, I'm not generally telling people that their baby has cystic fibrosis, but I've told a lot of older individuals, often with parents in the room, because they may be at kind of in that adolescent, young adult range, that they have a new diagnosis of cystic fibrosis. And the very first thing I do is I say, you know what, you're probably only going to remember about 10% of what I'm telling you here. So here's the link for the Cystic Fibrosis Foundation website. Go there, read it after we've talked and you've had some time to absorb, because everything is put into layman's terms, explained very well, and it's all good information and good data. What I don't want people to do is go home and Google, because then they'll just be terrified. So the Cystic Fibrosis Foundation, I always put that out there up front while people are still listening to me. And then I kind of try to move into talking about some of the basics, that it's a genetic mutation, and that genetic mutation results in a protein that isn't formed right and doesn't work right. Normally, that protein allows us to help chloride transport. And the reason chloride is important is because it drags water with it and helps us moisten surfaces. When that doesn't happen, a lot of the different parts of your body become gunked up with very thick secretions, and your body just isn't made to handle those thick secretions. And it affects a lot of different organs. It affects the sinus tract, the lungs, the GI tract, reproductive organs, just to name a few. And particularly in the lungs, all of that very thick mucus and secretions that builds up because of this lack of water causes you to be able to trap bacteria, other pathogens, and starts to destroy the airway over time because of chronic inflammation. So that's generally where I start. And that usually opens up a huge basket of questions. So I usually pause, delve into some questions before I do more explaining.
I think usually one of the first questions I get questions from, even like friends and family who don't only know like cursory, the thing they know most is you don't live very long. Like they're like, oh,
Sure.
Uncle Bobby, he died in his 20s and 30s, 20 years ago. What do you tell them about, because that's usually probably one of the first things they ask.
Yeah, and especially in my patient population, I get asked that a lot, because generally when I'm talking to folks and telling them that they have CF, they're already older and their disease might be more advanced at diagnosis. And so I usually tell them, the honest truth of the stats that we have right now. So the average life expectancy for CF right now is in the upper 40s. And which is a huge improvement from, even just a decade ago. But for little kiddos who are being diagnosed with CF right now, that number is going to look way different, because these kiddos are going to have the opportunity to grow up in the era of CFTR modulators. So CFTR, that's that gene that becomes abnormal, that results in that abnormal protein. And because of these new drugs that can kind of fix that protein, some of these kiddos are going to have a much different life expectancy and a much different life with this disease. So although right now, the numbers are still very sad, and it's something that we have a lot of work to do. Having a life expectancy in the upper 40s is not great. I think that's going to change every year. It's going to be longer and longer and longer as these kiddos start to grow up.
One of the things, I feel like I've seen younger kids with cystic fibrosis who seem pretty advanced. And then I've seen adults who really have pretty mild symptoms. And maybe it's just that's maybe anecdotal, but it seems like there's a pretty wide heterogeneity of the phenotype. Is that true? And is that because of access to medications, or is there a way to assess the severity of saying this child is going to have severe cystic fibrosis growing up, this one will probably have mild symptoms?
Yeah, so that's an excellent question. So genotype does predict phenotype to some extent. So there's certain genotypes that are associated with more severe disease. But that being said, you can have two patients who both have a delta F508 homozygous mutation of their CFTR. That's the most common mutation. And they may have very, very different manifestations of their disease in terms of their severity. Certainly, it's affected by access to care, access to therapies. And the CF Foundation has worked really hard to make sure that patients have access to the therapies that they need. But certainly if you have less resources to get therapies, less social support to make sure that those therapies are implemented, then that will affect your especially your lung function and probably your outcomes long term. But it's a huge spectrum. You're totally correct. The phenotypic expression is really variable.
Along these same lines, there's the different classes of mutations, and I'm totally a novice at CF. I have not seen many patients. Mainly, I've seen a couple patients in their 30s and 40s or late teens that get admitted to the adult inpatient hospital, like to the inpatient side. But the classes 1 through 3 are the ones from what I was reading that they present earlier in life, and then the other ones present later in life. Do most patients fall into the presenting earlier, where they're diagnosed at birth and they have problems throughout childhood? That's what I think of as the classic patient, but I'm not sure if the actual numbers bear that out. And is the prognosis majorly different between the two groups?
Well, so, the majority of people nowadays are being diagnosed on newborn screen, especially as newborn screening has become universal. But you have to keep in mind that it wasn't until 2010 that all states were doing universal newborn screening. Yeah.
Oh, I see.
So as of 2018, 83% of kiddos diagnosed under 1 were caught on a newborn screen. But the total diagnoses of CF in that year, only 63% of them were in that less than 1 range, and only 63% of them were newborn screen, if that makes sense. So we're still diagnosing a lot of older kids and adolescents and adults who were not captured by that initial newborn screening.
Do the people that you capture that are adolescents or young adults, do they tend to have milder disease? Because I feel like it would have been picked up if they were getting recurrent infections and bowel problems and all the other things that go along with it that we'll talk about.
Absolutely. So, if you're diagnosed later in life with CF, then you tend to have milder disease and some of the more rare mutations that are associated with milder phenotypes. I have a patient who was diagnosed in her 60s, and now she has fairly advanced lung disease, but she made it through, her 30s, 40s, with one or two pneumonias a year, but otherwise had fairly normal childhood and adolescence. So, and she has a more rare mutation.
For those patients that are diagnosed at a later stage, how are they diagnosed? Is there a sweat chloride test for a 62-year-old?
Yeah.
Or do you also mean how are they presenting? Like what is
Sure.
people to think that this person might have CF?
Yeah, I think both. I mean, I imagine that it's like these recurrent pneumonias that people are like, maybe we're missing something, maybe not. But I just can't imagine, I feel like the baby, it's like, oh, they taste salty. And it's like, oh, that's cystic fibrosis. But, the 62-year-old equivalent, I don't know. It's like, I think.
Yeah, we don't advocate for licking our patients.
That'll be in the show notes.
You can sweat an adult. So it's diagnosed generally with an abnormal sweat chloride. And then we do genetic testing to confirm the mutation because now it really dictates therapy. And also there are some pretty rare diseases that can give you an abnormal sweat chloride, and you don't actually have CF, but you may have other lung problems. So that's another reason to complete the genetic testing. But for adults, it's generally the adult who has had refractory uncontrolled asthma or multiple pneumonias, or holy cow, someone just figured out that you have horrific bronchiectasis, but nobody knows why. So typically they get some other label for a while, or they just struggle for a long time with infections and things like that, and they never get diagnosed until somebody kind of gets a hold of them and puts two and two together.
Now, I want to step back because we're probably going to have some listeners who are adult practitioners, have been a while since they've done a pediatric rotation in medical school, or some early learners. Do you think you can describe some of these diagnostic tests a little more? Like, what is a newborn screen and how is a sweat chloride test done? So that people have a better understanding of what's involved with these.
Yeah. So, the biggest important thing for adult learners that I would say with regards to the sweat chloride is if you have a patient that you think potentially could have CF, they have bronchiectasis without a clear underlying reason. They have some other recurrent forms of pulmonary or sinus disease, or maybe they have frequent pancreatitis without a clear reason, or male infertility with an absent vas deferens. That would be on my differential as well. Then a sweat chloride should be ordered on those folks, and it should be done by someone who is familiar with doing the test on a fairly regular basis. The CF Foundation actually helps us to track how we do with our sweat chlorides, how accurate we are with our diagnosis, how many people we sweat that come back negative. And so it really should be done by somebody, in that kind of a capacity. We have a CF nurse that does all of ours, and she's amazing at it. But it's pretty operator dependent. So my biggest advice would be refer to a center or someone who knows how to do a really accurate sweat.
This doesn't involve licking people, does it?
You should not lick people to diagnose them with CF.
Especially not during a pandemic.
No, like
exactly.
gauze.
And then
I was just asking. So, like, I've never actually seen one, but I've read about it. And so they put gauze on people, and they're given medications to make them sweat. Is that how it works?
Yeah, it will. And so our nurse has got it down to a science, and she can make anybody sweat.
She feeds them really spicy sausage or something like that.
Some really spicy Thai food. And then the cutoffs that you use, there's 3 ranges. So you can have after the sweat is collected, then it's sent to the lab. And then the cutoffs that you use are so a negative, an indeterminate or intermediate, and then a positive. And if you're greater than 60, similar to the kiddo, then that's a positive. If you're in that indeterminate or intermediate range, then you may want to send genetic testing, even though you haven't had a positive sweat, because there are certain genotypes that are associated with that. And then generally, if you're negative, you truly are negative, and you probably don't need to send genetic testing.
Whitney, we've done the thick and liquid challenge before on the show, and I really think we should have thought about doing sweat chloride tests on all of us just to go through it, just to see what it's like. I didn't really think when I was reading about it. I didn't really think about how they actually did it, but I want to see how this happens. I'm very intrigued.
You can YouTube it.
All right, we're going to find some YouTube links and we'll include it in the show notes.
Great. So let's keep moving. So, cystic fibrosis, a lot of us, we think the lungs are where the money is. It's, primarily a pulmonary disease. So let's say we're seeing Emma in the clinic regularly over the next few years. What are we looking for as far as pulmonary complications of cystic fibrosis, and how are we regularly assessing, monitoring, and following her pulmonary function?
So one of the things that you're looking for is infections. So, if she were to start to have respiratory infections, producing more sputum, coughing more, then that would be concerning for pulmonary complications. As kiddos get older, we start to do pulmonary function tests. So when they're older, then most kids can do it around 5 years old or a little bit older, depending on the kiddo. And then we start to track their FEV1, or their forced expiratory volume at 1 second, and their FVC, or their forced vital capacity. I mean, typically we monitor both. And you look for any decline in that. And then as soon as they're old enough to start giving sputum samples, we follow their sputum in addition every 3 months to make sure that they're not growing organisms that could be eradicated, or organisms that could be targeted in their next exacerbation.
That seems like a lot of work following sputum samples. Is that something that we've just done, or is that something that we know if we identify that someone has MDRO and we treat it, that it's going to improve outcomes? I'm just curious. It sounds.
So there are some outcomes tied to what you grow. So there is some benefit so the first time you grow Pseudomonas, there is benefit to trying to eradicate it. So that's one reason that we get sputum samples, to look for Pseudomonas and to eradicate it when we can. So we follow sputum for that reason. And then other things that patients may grow. So when they grow Mycobacterium or other non-tuberculous mycobacterial organisms, those may need to be targeted, especially if there's been a decline in lung function. And there's prognostic value to following sputum as well. Different bacteria are associated with worse prognosis, like the Burkholderia cenocepacia complex bacteria are associated with rapid decline in lung function. And so when folks grow that, then it tells us more about their overall prognosis, and we'll often try to treat that too. And then if they have an exacerbation, then you have culture data to know what to target for their exacerbations.
So essentially the flora, the flora, I'm not even going to try to repeat that name you just said, but the flora can be a sign of lungs that are getting sicker and progression of the disease itself.
Right. That's true. Yeah. And some of our therapies are based on what you grow. So if you chronically colonize Pseudomonas, and just to backtrack for a second, what happens in folks who have cystic fibrosis is they will develop a biofilm. So they have these thick secretions that develop a biofilm, often Pseudomonas, Staph aureus, some other bacteria and fungi that are fairly common. And then other organisms over time, as the lung function declines and there's more lung destruction, can be kind of a harbinger of progression. And when you first grow Pseudomonas, you try to eradicate it, but then if you chronically colonize it, then we know that things like chronic azithromycin may improve your outcomes. Inhaled antibiotics may decrease your risk of exacerbations and hospitalization. So there's different therapies that you can use to target depending on what you grow.
I wanted to talk about mucus clearance. I don't know, Chris and Justin, if you guys know much about that, but I was reading that this can take like 4 hours. Like it's a huge time suck for patients and their families. Can you talk about that a little bit? Do you prepare people for that?
Oh yeah, I when I'm counseling people, I tell them that they're gaining a new part-time to full-time job in addition to whatever else it is that they do. Most of our patients in the adult world do 2 to 3 times a day of an airway clearance regimen. And it's usually nebulized albuterol, followed by nebulized hypertonic saline, followed by some sort of percussion. So like aerobica, or they'll do vest, something to mechanically help clear secretions. And then once a day at least, most will do pulmozyme to help thin those secretions. And then most patients, especially adults, are chronically colonized with Pseudomonas. And so they'll do inhaled antibiotics on top of all of that at the very end. So twice a day or 3 times a day, they're doing some form of inhaled antibiotics. It's a big regimen. And if you're trying to have a job, go to school, have a normal life, it's pretty difficult.
Is there a justification for that order? I remember vaguely, like the albuterol opens up the airway to get the hypertonic saline in. Is that true? Is that evidence-based? Is that...
Well, if you've ever given hypertonic without albuterol, you'll see the evidence yourself. It causes bronchoconstriction.
Great.
So you can make somebody significantly wheeze with especially if they already have kind of hyperreactive airways. Hypertonic can just cause bronchoconstriction. So that's the purpose of doing the albuterol first, and then the hypertonic hydrates the airways and also stimulates a nice robust cough to help with airway clearance.
Now, is there good evidence about how good the vest therapy is and how those types of vibrations help with clearing airway?
There's been a lot of research that has compared the different types of mechanical airway clearance. So they've compared IPV with aerobica, with vest, with percussion, manual percussion, like clapping on the back and that sort of thing. And there's not ever been a lot of great data that one is better than the other. The nice thing about the vest is that you can do other things with your hands while it's on. And now that there's a battery pack vest that has kind of just come out in the recent years, I had a couple of patients in my fellowship training that would commute wearing their vest. So they had a portable nebulizer, and they would neb and then vest as they commuted. Ooh. So it was easier for them than doing something handheld because they were driving.
We got to get these self-driving cars, guys. I don't know. I don't want to take the podcast off, but I'm really excited about self-driving cars, especially since my oldest kid is about 8 years away from driving. Can't come soon enough.
Should I start shouting out to manufacturers so we can get some more bleeps in the episode?
If Tesla wants to be a sponsor, I guess we can.
Elon, come on. Yeah, I know you're listening. You know all about ventilators now too.
One more thing about this, that I think as far as going along with daily maintenance, whenever we have a kid that's admitted to the hospital, his diet, the cystic fibrosis diet, is always essentially double portions.
Yeah.
And we're encouraging them to get cheeseburgers and milkshakes. What's the story behind the double portions for cystic fibrosis?
There's a couple of stories there. So the first is, especially as the lung disease advances, the patient has a much higher metabolic demand. So just breathing is a lot more work for that patient than for someone without cystic fibrosis. So they burn a lot of calories just breathing. So they need a lot higher calories in that situation, especially in advanced disease. And then absorption is always an issue. We have our folks take enzymes to help with the pancreatic exocrine insufficiency that we see with cystic fibrosis, but absorption is always an issue that we fight. And so we're kind of fighting two battles: higher caloric demand and lower overall absorption. And so we double portion all of our adult patients as well that are pancreatic insufficient, especially.
And is there a relationship between BMI and lung function? Is that...
There is, yeah, there is. So low BMI or dropping BMI is associated with decline in lung function. And some of that is because as your lung function declines, that metabolic demand increases. You see the same thing, another adult corollary is like end-stage COPD. When you see people who have super advanced lung disease, they tend to get very, very thin. So as you work really hard to breathe, that your BMI drops just because you can't calorically keep up with it.
So it's another version of the pulmonary cachexia syndrome that people get with COPD. It's like a hypermetabolic state or a catabolic state. And
exactly, both.
Are you working with nutritionists? Are we just telling these kids to eat cheeseburgers and bacon, and can they get a vegetable in there? Is there, or does it not matter? You're just like, you need calories. So you're on like the US swim team diet, 8,000, 10,000 calories a day.
No, we're super lucky in the way that the CF providers that have come before me have sort of structured and recommended that CF be run. And we run CF as a multidisciplinary team. And our team has a nutritionist that works with us and comes to every clinic and sees pretty much every one of our patients every time and tracks their BMI really closely, tracks their vitamin levels really closely, because we have a lot of issues with vitamin absorption, especially fat-soluble vitamins. And she does encourage them to have high caloric intake, but she tries to make it sort of the right caloric intake. She still scolds them if all they do is pound, sugary sodas. So
that's encouraging.
But we try hard not to restrict, to put hard restrictions on foods.
What's next here, Chris? Do you want to go to the next part of the case?
Yeah, we can do the next part of the case. So Emma is now a 23-year-old college student and presents with a mild cold that began a couple days ago during finals week at school. During the interview, Emma reports having a productive cough, shortness of breath on exertion, and increased fatigue. So what should we do for Emma's cold? And how do we treat CF flare or pulmonary exacerbations?
Colds can be tricky in CF because sometimes it's just a cold. Sometimes you just need some supportive care. But a lot of times it doesn't take much to push a CF patient over the edge, allow that biofilm to really explode in their lungs, and then put them into a full-blown CF exacerbation where basically their immune system in their lungs just can't handle the bacterial volume. So generally, we treat CF exacerbations with a combination of increasing airway clearance aggressively, and then also starting either oral or IV antibiotics, depending on what they're sensitive to.
And so if Emma has a cold and let's say has poor sensitivities, we've been doing sputum cultures and she has a lot of resistance, does that warrant admission for IV antibiotics, even if she's doing okay otherwise?
Especially if she's having a drop in her FEV1 or her FVC, then it generally does warrant admission for IV antibiotics. So you generally try to treat based on like what is Emma's baddest bug, try to cover her organisms that she's recently grown. And if she really has organisms that are only sensitive to IV antibiotics, and then you would admit her to get her started. There's a lot of debate in the CF community about whether or not, people could then go home on those IV antibiotics after they've completed like a 10-day course, a 5-day course, because our general courses are 10 to 14 days. not based on great literature, but based on what's been done, practice patterns.
Now, what is the difference? I know we have inhaled antibiotics and IV antibiotics. Like, what's the difference, and why are some inhaled? Why aren't they all inhaled? Like, I don't really I think I'm sure I was told this at one point, but I can't really remember.
Great question.
The inhaled antibiotics we generally use for chronic suppressive therapy, especially in the setting of chronic colonization with Pseudomonas. So tobramycin, aztreonam, and colistin are the three most commonly used. And those will generally work for chronic suppressive therapy, but when people are really having an exacerbation, they generally will need an oral or IV antibiotic to truly suppress the bacteria and kind of allow them to go back to whatever is their normal colony forming units that they're able to tolerate and that their immune system is kind of able to regulate.
Are they usually multi-drug regimens when you're, and is it all just based on prior culture data? If you didn't have culture data, someone's, I don't know, they get admitted to your hospital, they're out of state for some reason. You just do your best, put them on IV aztreonam and.
I think you would, if I had somebody coming in, a lot of CF patients are super savvy. And when I've admitted CF patients who I don't have any culture data on them, I'll often ask them, what do you grow?
Oh, this is a good point.
And if they're like, oh yeah, I grow MRSA and Pseudomonas, and they tell me my Pseudomonas is resistant to everything, then that helps you. Or if they say, oh, I grow Pseudomonas and I usually get treated with oral antibiotics, then you kind of know they probably have a pretty sensitive strain of Pseudomonas. And I would judge it, based on that. Most of the time, by the time they get to me and they're adults, they know what they grow. Otherwise, I would just pick, your most likely bad actors. So Pseudomonas and MRSA are our biggest problems. I would double cover for Pseudomonas and I would cover for MRSA until I got a sputum culture.
So for those multi-resistant bugs like a Pseudomonas that they tell you it's resistant to everything, what do? You just give them what you can and then pray? And this is an issue I know, like not just in the CF patients, because we have a lot of resistance out there.
Yeah, so actually there's been a couple of studies that have looked at this. So in folks who have Pseudomonas that's just resistant to everything, if you pick two fairly good anti-pseudomonal drugs, so like an aminoglycoside and something else that generally has fairly good pseudomonal coverage, so like cefepime, or if they're very, very ill, maybe even a carbapenem, then even though their lab data would suggest that they're not sensitive at all, individuals still tend to get better from that CF exacerbation with those antibiotics. And there's a couple of proposed theories, and these are just theories, so nobody hold my feet to the fire on this. And they're not my theories. They're theories put out by people way smarter than me. But some of the proposed theory is that sometimes your in vivo sensitivity may be a little different than your in vitro. And also that those antibiotics may just allow enough suppression of the bacterial load that the immune system can kind of take over and the patient can get through the exacerbation.
So to recap the exacerbation stuff, because I know we still have a lot of things left, they're going to be doing all their full-time or part-time job of mucus clearance in the hospital now. The main difference is they're just going to be getting intravenous antibiotics. And in my experience, these patients often don't look that sick. Like they're often like on laptops, right, and they're, listening to music, talking on the phone. Like they tend to be, to look at them in some ways healthy. It's a little hard to know, but it sounds like you said maybe 5 days you can keep them and then potentially send them home with it, but that's controversial. So what is a typical endpoint for a patient in the hospital?
So generally we're doing Spiro about halfway through their antibiotic course and making sure that their Spiro is starting to recover. So that's one endpoint. There's a couple of trials going on right now trying to determine what are those endpoints and how long should we be doing antibiotics. A few studies have compared doing the whole course at home versus partial courses at home versus the whole course in the hospital. And in general, folks do better in the hospital. And we think that's probably mostly because of airway clearance. when we have folks in the hospital, we have them doing airway clearance 4 times a day. And that's a big lift at home.
To Matt's point, there's still a lot of other complications and things that we want to talk about and touch base on. In keeping up with Emma, let's say now she's 35 years old. She finishes college. She got a history PhD. And she's coming into clinic for an annual checkup. She has a 2-hour plasma glucose that is 208 or elevated. What are some things that we're checking for? Why do we do an oral plasma glucose? What are some of the extrapulmonary complications of CF? When do they typically present? And are patients on medications or other maintenance therapies to try to prevent these extrapulmonary complications?
Yeah, so there's a lot of extrapulmonary complications, and especially, they can present as early as infancy, especially some of the malabsorption. That's why you may see failure to thrive as the presenting symptom in an infant. But as they get older, especially adolescence and into adulthood, you start to see a lot more diabetes. You start to see a lot more bone disease. You may see more liver disease, although that can be in childhood and infancy as well. Certainly sinus disease, fertility issues, pancreatic issues, pancreatitis, endocrine and exocrine insufficiency. The reason we do oral glucose tolerance tests is because CF patients have more rapid red blood cell turnover. We think some of that is tied into changes in metabolism. And so hemoglobin A1C tends to underestimate their actual blood sugars or blood glucose. So that's why we do oral glucose tolerance testing.
So what is the difference between like a CF related diabetes with like the diabetes we see in our adults, like mostly type 2 or the type 1s that we see in our children?
CF, I've heard a couple of endocrinologists who are very experienced with CF talk about how it's some horrible combination of type 1 and 2. You have an absolute insulin deficiency, but then you also see some insulin resistance in addition. So they are in a chronic pro-inflammatory state. So they typically will have some insulin resistance. And then because they can also have some issues with absorption, gastric emptying, GI transit, they can get insulin food bolus mismatch and have really difficult to control brittle diabetes with like very high blood sugars and then very low when they get kind of like an insulin mismatch. Every CF patient who has diabetes benefits from seeing an endocrinologist familiar with CF if it's available.
And oral meds they're a no-go, right?
That's another controversy. So recently at the CF conference, there was some really good presentations on sitagliptin and metformin and maybe using early in disease, but there's probably more to come on that. In general, insulin is what's recommended. The CF Foundation guidelines recommend
Okay.
insulin.
And you're not going to want to slow gastric emptying with like a GLP-1, I guess. And if they're totally insulin deficient, the SGLT2 is probably not going to be.
Yeah. You definitely don't want to do anything to slow GI transit because we already have issues with that in CF. So you probably want to avoid those.
Going back to the difference in phenotypes, are the extrapulmonary, is the severity of disease often in line with pulmonary disease? Is the people that have really bad CF-related diabetes, do they also have really bad lung function? Or can some people just have bad luck where their cystic fibrosis affects their GI tract or their endocrine system? Do they go in parallel or not?
There certainly are some genotypes that are associated with just broad spectrum, severe phenotypic expression. But there are also more rare mutations that are just associated with like very severe pancreatitis. So kind of a different manifestation, or very severe sinusitis with very mild lung disease.
So one of the issues that comes up with a lot of these pediatric diseases that go into adulthood is some of the challenges that go with transition. And so when you have an adolescent or a young adult in your clinic, how do you talk to them about exercise or going to the gym or drinking or what their reproductive consequences are of cystic fibrosis, and maybe even if you talk about when you bring them up, how you bring them up, some experience of what that's like.
Absolutely. I think fortunately, there's some really great programs that start that pretty young for CF, realizing that these kids are going to grow up to be adults with a pretty serious chronic medical condition that they're going to have to take control of. So CF Rise is actually a program for transitioning from pediatric to adult medicine and helping kids to start learning their care regimens and learning what all it is that their parents are doing for them, and then gradually transitioning to take over their care so that by the time they are to me, they've had years and years of taking over their care. And so the nice thing with the implementation of CF Rise is that when they get to me, even if they're like 18 or 19, they're pretty used to talking about their medical condition like an adult. And it's not across the board, but a lot of them are pretty used to having good, frank discussions about their own medical care. So generally, I don't start talking about sex on the first visit. But after we've gotten to know each other and have had maybe a visit or two, then generally I'll bring up like, now that you're in the adult clinic, things that we talk about in the adult clinic are exercise, alcohol use, sex. Why don't we start? Well, you pick which one you want to start with, and we'll start talking about it, and make sure that you don't have any questions, and make sure that you understand everything about how your disease affects those things. And most of my patients are incredibly open to that. Because they've had such a long time of already being sort of the managers of their care. And it's not universal, but CF Rise has really, I think, set kids up to be successful in those discussions, getting them comfortable having them. It's always tricky when you're talking about sex, because I think there's, especially my male CF patients are like, well, I can't get anybody pregnant, but I often sort of joke with them, but yes, you can still get an STD. So, that helps me sort of transition to more serious conversations of like, 97% of males with CF don't have a vas deferens. But in the future, you should think about that sperm harvesting is still a possibility. So, keeping yourself healthy if you want that possibility in the future is super important. And you can still successfully have your own biological children if that's what you want. Because some of them have never heard that like, oh, that's something that I could do. That could be one of my goals if that's what they want.
And for women, is pregnancy particularly dangerous? I have no knowledge of this. I did not read about it beforehand.
Yeah, well, so it sort of depends on the patient's lung function. So a lot of women with CF can get pregnant. It often just takes longer. So the cervical mucus is really thick, and that can make it harder to get pregnant. But usually within a year of trying, about 80-ish, sometimes a little bit higher percent of women with CF will be able to get pregnant. We generally recommend patients with an FEV1 less than 60% not get pregnant, because they tend to have worse outcomes for themselves and then also for the baby, growth restriction, fetal loss, a lot of different problems that come along when your lung function is very low.
Now with CF patients who want to pursue having children, do you feel they have enough information to make those decisions on their own? Would you ever refer them to like a genetic counselor to discuss these types of things? What's your experience?
Yeah, absolutely. So whenever, I try to have that conversation pretty early with patients, because it can have, especially if your lung function is very low, it can have a lot of consequences for a woman. And so I, as a part of their medication list, often I'll be like, oh, are you on oral contraceptive if you're sexually active? And then, well, why don't we talk about this for a second? It's kind of a nice segue. Just to make sure people are super aware of the fact that they can get pregnant and sort of what some of the outcomes are associated with that. But I always offer a referral to a genetic counselor if people want to get pregnant, because I think that's a really important conversation to have. And the geneticists are really the best setup to have those conversations.
Can Emma have a beer?
Well,
she's 35.
I'm just, I know, yeah. So again, I try super hard not to have a lot of hard no's with my patients. It's a team. We come to joint decisions, joint decision making. It's not like Dr. Warren's way or the highway. And so what I tell people is you got to be careful. Excessive alcohol can be a little more dangerous in CF. You are in general higher risk for liver disease. You're higher risk for pancreatitis, and you're higher risk for diabetes and loss of bone density. And all of those things can get a lot worse if you have really heavy alcohol consumption. And so I definitely discourage heavy alcohol consumption, but I also realize that I can't, I can't just lock up my CF patients and tell them not to have a life and live their life. So we try to encourage moderation. And caution.
What if she wants to do either weight training or like training for a 5K or 10K? Do you encourage physical fitness for your patients?
Oh yeah. Yes, absolutely. We are the biggest cheerleaders of exercise. In fact, we try to get people when they're admitted, if they're well enough, to go to the hospital gym and work out, or at least walk the halls, or we have some cycles that can be sterilized and encourage them to cycle in their room. Exercise is amazing for airway clearance. And so we really encourage that. And then weight training is fantastic because we have a lot of issues with bone density in CF because of malabsorption. And so weight training is fantastic for improving bone density.
So now, as Emma's getting older and we're getting newer therapies that are out there, what are some of the latest treatments for CF, and where do we see the treatments of CF coming in the future?
The CFTR modulators are the latest treatment. So they work in a number of ways. And this is probably what I'm most excited about, because the CFTR modulators are changing the face of CF. They are changing the disease. Basically, they work in a number of ways to change the way the protein folds, or keep the protein at the cell surface longer, or keep the protein open longer so that more chloride can go through. Some of the older ones are approved down to 6 months. Some of the newer ones that are the most efficacious, you have to be 12 or older to take them. But we think eventually those will be approved down to 6 months as well. And I just cannot imagine how great it will be when, every 6-month-old who has a delta F508, at least one copy, or other mutations that are appropriate, can start on these drugs. And then by the time they see me, they have much better lung function, much more preserved, much fewer exacerbations. My dream is that someday all of my CF patients will look at me and say, "I'm going to outlive you, Warren," and that I don't have to be, looking at young people that wouldn't be able to say that. And the modulators are really making that happen. 90% of CF mutations are now covered by a CFTR modulator, and that's huge. But for the 10% of patients, those patients who have missense mutations, the modulators don't work for them. And so that's where we really need genetic therapies to intervene. Things like CRISPR. The CF Foundation is heavily funding different genetic gene therapies to try to advance progress for those folks, because really right now there's not a lot of options for them in terms of more definitive treatment. So
what these newer CFTR modulator therapies, are they usually covered by insurance, especially for these patients who are diagnosed with CF, or is there still a constant fight since these are new therapies?
It's tough. So a lot of the insurance companies are covering these. Now, some of them come with hefty copays depending on what type of insurance you have. The CF Foundation and then some of the pharmaceutical companies that are making these have very good patient programs. And then there's a number of foundations and grant programs that patients can apply for to help cover copays if they are insured. Very, very difficult to get if you're not insured. The newest modulator per year is in the hundreds of thousands of dollars per year.
One of these patients ever thought about, is lung transplant ever a thing? Is it considered?
We talk about referring for lung transplant if somebody is having a rapid decline. Once their FEV1 is in the 30 to 40% range, we talk about transplant. There's a couple of other prognostic features that we look for that make us refer. The biggest thing that I could sort of put out there is early referral is super important. No transplant center will ever say you referred this person too early. They will just say thank you. If they're really not ready for a transplant, they'll follow them annually. But late referral is so much worse than an early referral. So getting these people to a transplant center, especially if they have advanced disease, super important.
Any other therapies that we are seeing on the horizon? And what's your prognostication on how CF patients are going to fare in the future?
I think with the huge strides that have been made with modulator therapies and then, hopefully some of the gene therapies that are on the horizon, my biggest hope is that, well, first off, that CF is cured completely. That would be fantastic. I would love to be out of a job completely. That is my real dream, to be out of a job. But also to see this transition from, a disease that takes people very young. As I get older and older, upper 40s looks pretty young to me right now. But see this go from a disease that people don't die from, they live with. And then we can manage it more like some of the other chronic diseases that we see. That's what I see, for the future of CF. Hopefully a cure, but at least getting it to more of a manageable chronic disease.
I think you're right, Whitney. They're doing amazing things these days with genetics, and you said CRISPR, some other words like that. It's gonna be fine.
Totally.
Yeah.
And we'll find something else for you to do. People are eValley, vaping associated lung injury. That's not going anywhere.
Whitney, are there any main takeaway points that you want to make sure our listeners gain from this episode?
I think the biggest thing is you're never going to diagnose CF unless you think about it. So if you have a patient that is having recurrent sinopulmonary disease and you haven't got a good reason, then think about CF, send them for a sweat chloride. The earlier you diagnose it and start treating it, the better they're going to do. If you have a patient with CF that has advanced lung disease, refer them early for a transplant. Those are probably the two biggest takeaway. Get them to a center so that they can be cared for appropriately. Before
we let you go, do you have anything you want to plug?
Can I plug the CF Foundation?
I was going to ask because you brought it up multiple times, and I was going to ask, what is the CF Foundation? It sounds amazing. Tell us.
The CF Foundation is an amazing nonprofit organization that contributes to the creation of the CF guidelines. They put on a fantastic conference every year. They sponsor hundreds of thousands of dollars, probably even more, in research towards curing CF and improving the lives of patients with CF. It's an incredible foundation. If anyone is independently wealthy, please donate to the CF Foundation. It's an organization that really takes every dollar and does a lot of good with it.
Thank you. Elon, if you're listening, just throw him some money.
Yeah.
CF Foundation, Elon.
Astronauts up into space. Now we just got to work on CF.
Exactly.
This was awesome, Whitney. This was amazing. I learned a lot.
I learned everything.
Learned a lot. And I think I think this will be really good.
This has been another episode of the Cribsiders.
It's for the kids.
Love that. Get our show notes and sign up for our mailing list called Knowledge Food Formula Feeds
Yummy.
at thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecribsiders@gmail.com.
A special thanks to our wonderful producer for this episode, Clara Mao. Thank you guys for tuning in. I've been Justin Lee Berk.
I've been Matthew Frank Watto.
I've been Clara Mao.
And this has been Chris the Chi-Man Chiu. Thank you and good night.
You've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by the VCU Health Continuing Education. VCU Health is jointly accredited by the ACCME, ACPE, and ANCC to provide continuing education for the entire healthcare team. Check us out at ce.vcuhealth.org/Cribsiders for more information and to claim credit after listening to this episode.